there's more people joining because it's so cold, and I think SWEP's open everywhere. So I imagine that many people will have been called out to do emergency things and they rightly are prioritising. But it's really good to see so many people here. Sophie, thank you for organising the programme. As always, we're going to hear about RAMP evaluation, and then we're going to hear about a pathway and crisis project on duty to refer, and then we're going to use the time left for a discussion about how can we make sure that homeless mental health isn't forgotten. So it'd be really in the current crisis times for the NHS, which I think is really important, and it'd be useful to hear about how people are experiencing that at the moment, and any thoughts about how we can make sure our voice is heard. I think we've got the first speakers here, so I'm going to hand over to Hilary and Johanna to talk about RAMP.
Hi, yeah, I'm going to share the slides here, if you give me a sec. Okay, hopefully you can all see that. I'm going to be talking about the Rough Sleeping and Mental Health Programme, RAMP. Thank you for inviting me. So I'm Johanna. I work in the GLA in the rough sleeping team. So we are a small team that commission a range of rough sleeping services. They tend to be kind of pan-London services designed to complement what local authorities are commissioning and delivering locally. So I'm presenting with Hilary, who many of you probably already know, but Hilary, do you want to introduce yourself?
Yes, I'm Hilary Neal. I'm team manager of the East London Foundation Trust RAMP service. So we're the service that covers City of London, Hackney, Tower Hamlets into Newham.
Great. So just in terms of the agenda, we are going to be going through just some background to RAMP, the overview and principles, and then talk about the successes in learning and primarily kind of talk through the evaluation of the RAMP service, and then a quick update on what's next. So in terms of the RAMP programme, we funded RAMP to set up in 4 London NHS trusts. So you can see the 4 areas on the map. They started in March 2020. In terms of the boroughs, the areas that were kind of chosen to deliver this, obviously some of the boroughs already had specialist provision, so START and the GHT team, so there was already kind of some specialist provision operating in London. So we looked at the areas that didn't have any specialist provision and then prioritised the areas that had the greatest needs, so the highest number of people rough sleeping. So the funding was from our funding, so GLA funding, and then we also received some from central government as well. And at the beginning of the programme, we estimated that the programme would support about 1,150 people over the 2-year pilot. So this is a picture of the kind of timelines that we had. So as well as the 4 trusts that we funded, we also commissioned an organisation to provide coordinator support. So ICHP, Imperial College Health Partners, who kind of worked very closely with the trusts and helped set up and coordinate the running of the programme. So in terms of code development at the beginning, that was really key, and there was a lot of work done to work with the trust but make sure that local authorities and outreach teams also were able to share their views and contribute to kind of what the services and pathways would look like. EASL is also a service that was operating in those boroughs and carrying out mental health assessments for people rough sleeping, and they had a really good idea of kind of some of the challenges and pathways locally, and were really helpful in that co-development phase. In terms of delivery, important to note that just as the services were kind of setting up and starting, COVID hit, so that did have an impact on the programme, and the teams had to adapt. I think it also had an impact on some of the evaluation as well, which I'll talk about in a bit. The funding was for 2 years. It was very much from the start a 2-year pilot with the aim that the trust would find sustainable funding after the 2-year pilot. So this is just a quick overview of what the RAMHP programme was kind of aiming to do. So in terms of need, in London, we know that there's in terms of our chain data, about 50% of people recorded on chain are recorded as having a mental health need, and yeah, a strong correlation between mental health need and length of time people spend on the street. So from the beginning of the programme, there was a kind of strong focus on partnership working. And the teams were kind of designed to be dedicated teams of mental health practitioners that worked really collaboratively with the outreach workers on the street to provide flexible and accessible mental health support. It was also very much a learning pilot from the beginning, and as part of that learning pilot, we made sure that there were structures in place to help reflect and learn. So, for example, the community of practice that's still going on at the moment. Training was part of the programme as well, and encouraging improvement projects. So these are the team structures that were set up. Funding allocation was based on the level of need in the different areas. All of the kind of team structures were slightly different. I think the most significant difference, so West London, East London and North East London all had a central kind of team that kind of worked together and operated kind of across the whole area. For CNWL, they adopted a slightly different model where they used the funding to fund staff posts that were then embedded in the local borough kind of CMHT teams. Just a note on the service principal report. So this is a report that was completed by ICHP and kind of draws out some of the core principles of the RAMHP teams. I won't go through them all, but definitely if you're looking at setting up a similar service elsewhere, then it's almost a bit of a kind of how-to guide, and it was circulated as part of the agenda. So definitely encourage you to have a look at that. So in terms of the RAMHP successes and learnings, so we commissioned UCL partners to conduct an evaluation of the programme. And they kind of broke the evaluation down into 3 key themes. So I'm going to talk through the first theme and then hand over to Hilary. So the first theme is RAMHP and the lives of people rough sleeping. Just before I get onto that, just quickly, these are the referrals that were processed by the RAMHP team across the programme. So in total, it was 1,712 referrals that were processed by the RAMHP team, so quite a bit higher than we kind of originally anticipated the programme supporting, and certainly kind of the feedback that we had from the teams during the programme was that they all felt very busy. Then in terms of the evaluation, so one of the aspects that they looked at was the impact on people's mental health. So they found that there was some indication that the mental health of people rough sleeping was stable or improved. I think UCL partners said that there were limitations in the conclusions that they could draw around this because the data set was quite small, and obviously with a bigger data set, they could draw stronger conclusions. So this is actually data from ELFT and looking at 134 referrals. So they used the HONOS scale, which is an outcome scale and clinician reported outcomes measure. So UCL partners took the average score at the initial assessment for the 134 referrals, and then the average score across the 12 markers at the final assessment, and were able to see that there was a clinically significant improvement in areas 2 to 12 on people's mental health. So the other kind of really key area was accommodation outcomes. So when we set the programme up, supporting people to leave rough sleeping was kind of one of the principal aims of the programme. I think we recognise that it's not the responsibility of the RAMHP teams to find accommodation for people. It's primarily the responsibility of outreach teams, but the RAMHP teams are able to unlock accommodation that might otherwise not have been available to people. I think this this area was impacted quite significantly by COVID. A lot of people who the RAMHP teams were working with were in emergency accommodation because of everyone in. Yeah, that probably had a fairly large impact on the data around this. So UCL partners looked at 2 measures. They used chain data, and for anyone outside of London, chain data is our London database, and essentially outreach teams kind of update everyone every time they see someone bedded down, update chain. So it gives us a pretty accurate data on whether someone is currently rough sleeping or not. And they looked at people who were kind of rough sleeping prior to their so immediately prior to their first contact with RAMHP, and then they looked at the whole cohort. So for the whole cohort, there were 854 people that we had a chain number for, and we found that 70% of people who received support from RAMHP were not seen sleeping rough again within 12 months of discharge from the service. So, we think that that's a really kind of significant positive outcome. And I think particularly kind of almost by definition of the RAMHP team, the teams are working with people who have the most complex needs. So really positive to see that kind of people's accommodation, it was kind of long-lasting solutions to homelessness that were being found. I'm going to hand over now to Hilary to talk through the next 2 themes.
Thank you, Johanna. So one of our outcomes was to sort of measure whether people were registered with GP surgeries. I have to say, the fact that we set these services set up over the pandemic, I think actually worked to our advantage with this particular outcome. I think many more people did register with GPs over that time, and probably influenced our data that way. We're assessment and liaison services, and we work and NHS services, and work in partnership with our third sector organisations and the street outreach services, doing joint outreach shifts, targeted assessments together. And there's definitely anecdotal evidence of sharing of skills and increasing skills, excuse me, and our and the street outreach teams have all talked about sort of thinking about how they approach their service users differently, and I think also the RAMHP teams have also have learnt their outreach skills from the street outreach teams. As assessment and outreach services, we have a slightly lower threshold to services than maybe other mental health services. So it has been easier to, for rough sleepers to access a mental health service. We are referring a small percentage of people on into secondary care or primary care mental health services. What we're trying to do is to influence the wider service to treat rough sleepers differently, so that they can they're not receiving the same barriers as they were before. I have to say that's possible. This is part of a work in progress. We might not have achieved that just yet. It's definitely an advantage that as a service, we are NHS services. We have the access to sharing information between different services, and that's I've got a case study coming up, and that will and that's definitely supported the way that we work. The other thing I'm going to pull out about this is that lived experience has been important from the very setup of the services. Each of the services had a steering group, and there were people with lived experience of rough sleeping, a part of those steering groups, influencing the way the services are run. Let's go to the next slide. Now, this case study is made up. It's not it's not a true story, but I think it will show a little bit about the way we work. It's the story of a 52-year-old man who had slept outside a local church for 3 years, sitting on his own, rarely talking to anybody. Well known to the street outreach team, well known in the local community, people bringing food and blankets, declining support that's offered, disappearing quite often if people seem a bit more invasive, and had been understood to have been admitted to hospital about a few years before, concerned that may have some cognitive impairment. An assessment had started, but he'd been discharged before the assessment had been completed. So what RAMHP did was to approach this man several times to be able to meet and understand his needs better. Got a lot of collateral information from old paper notes from 20 years ago that showed that the person had been admitted once under the Mental Health Act with psychosis. Had got collateral information from homeless organisations, GPs, and a relative who had sporadically called services with concerns, and RAMHP were able to identify this person and get more of the story there. The team thought that the presentation was possibly due to an untreated mental illness such as psychosis, and went ahead and organised a Mental Health Act assessment on the street. And once Peter had been admitted to hospital, the role of RAMHP was to in-reach into the hospital and the ward rounds and work with the ward team to bring a different perspective to the needs of the long-term rough sleeper. And raising awareness around the complexity in rough sleeping and how it impacts on the mental health presentation. Next slide. I know that we'll be running out of time here, so I'm not going to go through all the reflections and recommendations. I think they kind of speak for themselves. Johanna, do you want to step in?
Yeah, just to kind of pick out a couple. So the recommendation around investing in good quality data, I think is worth a mention. We definitely, across the programme, there were some kind of challenges in collecting consistent data across the 4 trusts because of the systems all working slightly differently, definitions being different. So the recommendation of the report is that teams should have admin staff, so a dedicated resource to ensure that the kind of data capture is good. And they also recommended continued analysis of housing outcomes for this cohort. That's obviously something that kind of sits on the housing and rough sleeping side of things and not within NHS trust. So then in terms of partnerships, I think there was a recognition within the report of the structures needed to be in place to support partnership working. So we had, as part of RAMHP, communities of practice where people could kind of share learning. We also commissioned, as part of the programme, joint training sessions and the joint shifts that happened between outreach teams and the trusts were a KPI and something that we monitored as part of the programme. So lastly, just to kind of pick out the influence on the wider pathway, I think Hilary kind of just mentioned this and the influencing other kind of teams within the trust. A part of the recommendation in the evaluation is that when commissioners commission RAMHP teams or similar services, that should be part of the remit from the beginning, that role in kind of influencing the wider system. So finally, what's next? So the pilot ended in March 2022, so almost a year ago now. So the RAMHP services have continued in all 4 trust regions. So 3 of the trust regions have continued it kind of fully, and 1 trust region has kind of partly continued it, a bit more of a mixed picture there. We also, so the GLA have received funding from central government to set up 2 new RAMHP teams in the south of London. So we're going to be working with South West London and St George's and Oxley's NHS Trust to expand RAMHP into those 2 areas, and they are due to start very soon. Okay, thanks everyone.
Thank you, Hilary and Johanna. That was really interesting to hear about, and great news. My question was going to be whether they were all continuing, so it's great news that they are and that it's expanding to the other boroughs. I don't know if people want to raise their hands with questions or put them in the chat. Do either, I guess. How did you feel about the whole COVID thing? We had a pilot that started just at the same time as COVID happened, and it made data collection interesting, I think. Were you going into the hotels?
Yeah. Just I guess to start off on that, I think in terms of having a planned approach to data collection, I think it was a lot harder at the beginning because the teams were so focused and rightly prioritising kind of delivery. It put us a little bit on a back foot in terms of data collection from my point of view. I don't know, Hilary, if you want to add to that.
I came into post in March 2020, which and I think the services kind of, we all started around about a similar time. you start a service in the environment that you're in. So I kind of didn't know anything different at that point. So it definitely had the biggest change. Initially, we were a service for rough sleepers, and then we changed our criteria for rough sleepers and people in emergency accommodation or COVID accommodation, and we've kind of kept that sort of emergency accommodation longer term now, certainly in the ELFT service.
Adam, your hands up.
Yeah, hi there. I've got my hat on because it's cold up here. I was interested, I did have a read of the documents you sent around, but I couldn't quite glean it from it, I think. I was wondering what the sort of definitions of mental health treatment were, like what was actually being provided, and whether there was any difference around different uptakes for particular types. I guess the classic ones are going to be some sort of medicine or some sort of therapy. Well, I only say that because we had in one of our meetings yesterday, there's always an interesting discussion about the narrowness sometimes of what the mental health interventions are that are actually being offered. And for a lot of the people we meet on the streets up here, there's much broader sort of things that might be good for their mental health, like phoning Scottish Power and sorting that sort of shit out, rather than trying to engage in any particular sort of treatments that we would typically see as mental health treatments, if that makes sense.
I suppose we the reason for referral is much lower than ordinarily for the majority of mental health services. So somebody might identify as having a mental health need, and we're very happy to see the person. And maybe it's actually the intervention is the assessment in itself, and having a conversation and sort of understanding and the person and the person is experience is acknowledged, and I think and actually I think that's a very incredibly valid piece of work for us to do. I think because referring into mainstream mental health services can continue to be a real challenge for our client group, either from the accommodation or maybe concurrent drug and alcohol use. We may see people for a handful of sessions, or that we might be doing a piece of engagement work where we're seeing somebody for much longer, but sort of on regular times, to try and sort of develop some attachment, to then sort of work more closely with maybe outreach services or other third sector organisations that in reality are providing that longer term work. Yes, we do work with people with mental illness, and we have a psychiatrist on our team, and we can start a prescription, and yes, we can get involved with Mental Health Act assessments. But I have to say that's not the majority of our work. And yeah, knowing how to sort out your finances and that kind of stuff. I mean, for all of us, that helps our mental health, and sort of knowing who to have the best conversation about that. Yeah, no, absolutely, that's really important.
I think I'd just add, I think so I guess the criteria and the pathways do vary a little bit between the different RAMP teams, and that kind of early period around co-production and really understanding what was needed locally and how the local systems work and how the RAMP teams fit into that, I think was really important.
I can just make a comment on that point of Adam's. One thing I've noticed from many years of working with a mental health team, START team, is that most mental health teams, specialist mental health teams for people who are homeless, have a lot to teach the rest of psychiatry, because they realise that you cannot engage with any treatment, whether it's psychological or pharmacological, unless you have a relationship with the person to start with. And that relationship for people involved in physical extremes means addressing practical issues and things that are of interest to them. Otherwise, engagement doesn't happen and nothing else follows. So I think we sometimes undersell what we do as homeless services, because this is a different model of providing mental health care to what you find in many places.
Yes, and it's a bit difficult, isn't it? I remember in the hotels particularly, we were seeing people, a lot of people we had very low thresholds then, and we just see anyone who wanted to talk to us really, or anyone felt that we should talk to. And I felt I was selling a bit of a lie really, because I was sort of going and saying, oh, we can help you and let's have a chat, and then thought when they leave the hotels and they go to wherever their house, if they get in touch with mental health teams, they're unlikely to have the same response or reaction, which I found a bit difficult. So maybe we need to get the rest of the mental health service up to our level.
I appreciate those comments, particularly what you mentioned, Phil. I do think mental health service have a great deal to offer. I think sometimes third sector staff, in my experience, to get quite annoyed when there's an idea that all the work they do is in some way preparatory to get to the goodies which are in some clinic somewhere, rather than actually, no, that's the mental health intervention, these years of building the trust and connection with people who've had huge relational injuries and, you know, require a trust repair service far more than they do a discrete intervention service, which professions like mine get very interested in, I think.
Yeah,
absolutely. Graham from Dorset, your hands up.
Thank you. Yeah, I just sorry if I've missed this point. I just wondered if there was a sense of kind of what size team you had. I've read kind of the people in your team, but I wondered what kind of numbers you had, because I think I reamed correctly that you roughly per quarter there's about 250 referrals, and I'm just wondering what kind of size team you had. That'd be interesting.
Do you want to go, Hilary?
So in East London Foundation Trust, we're very fortunate to have a team of about 9 of us. We've got mental health professionals, band 6s, that could be nurse, social worker or OT, but then we also have some specialist staff, OT, peer support worker, psychologist, and of course we have a psychiatrist 3 days a week, which is great. But I think each area has a slightly different, so each RAMHP team has a slightly different makeup. I happen to be interviewing for a speech and language therapist tomorrow, which I'm very excited about too, and think that will add something very different to the way that we work, and hopefully the wider system working with people too.
I think the original funding that we provided to ELFT, they were able to find kind of additional funding on top of that to expand the team from the original slide that I showed you. The kind of 2 new RAMHP teams that we're looking to set up will essentially be kind of 2 mental health practitioners, service manager, and some psychiatrist or psychologist input. And importantly, as part of the recommendation, there was a bit of admin support there as well that's been factored in to help that data collection.
Thank goodness. It's wonderful to get the data. I think it's been missing from the world of homeless psychiatry. So wonderful to have something you can say, look, this works. Because I noticed that some of the teams had psychiatrists and some of them didn't. How did the team makeup get decided upon?
So that was all done kind of locally. Trust made kind of different decisions. I think the feedback that we got, the areas that didn't have psychologist input wanted psychologist input kind of on reflection, and the areas that didn't have psychiatrist input wanted psychiatrist input on reflection. So I think I don't know, Hilary, if you want to talk about kind of your local processes.
We started off with psychiatry a day a week, and yes, we were able to secure some additional funding to sort of boost that, so that was great. I spent a long time trying to recruit psychology and failing, but we eventually, so for the last year we've had a psychologist, and their input has really boosted the way that we work with individuals, and think about people too, and think about people's experience. I want to say yes, administrator, for helping us with our data collection, and organising it is essential.
Okay, well, I think it just brings it home that it's truly multidisciplinary work, isn't it? And you kind of need all those elements. Wonderful to have a speech and language therapist. I'll be very interested to hear how that goes. Like a speech and language therapist. Okay, unless there's any other, I don't think there's any other hands up. So with that, we'll say thank you very much, Hilary and Johanna. That was really good to hear about, and great to hear that you're all continuing and expanding. So we'll hopefully in the end have provision in all areas of London. Let's move on to hear from, hello Chris, I think I've seen that you've joined. There you are.
Hi, hello.
Chris and Emily, isn't it, to tell us about the joint pathway and crisis projects and the duty to refer. I hand over to you.
Thanks, Jenny. I can start by introducing myself. So I'm Emily. I'm the policy officer at Pathway, and we're here to talk to you today about projects we are running in collaboration with Crisis. So I will let Chris introduce himself as well.
Hi everyone, I'm Chris. I'm Senior Policy Officer at Crisis, leading our work on health and social care.
So yes, as I mentioned, Pathway and Crisis have entered into a partnership, and one of our joint aims is to establish and secure the policy developments that we feel are required to pivot the homelessness system away from crisis management towards a more preventative approach. And we felt that having a better understanding of how the duty to refer is working in hospital departments would help to inform this thinking around our joint work in securing policy developments in preventative action. So I'm sure some of you will have extensive knowledge of the duty, but just to reiterate for anyone that might not be familiar, the duty to refer is a result of the Homelessness Reduction Act, and it places a duty on specified public bodies such as hospitals, prisons, and job centres to refer service users who are at risk of becoming homeless to a local authority housing team. So our aim for the project is to speak to staff across different sectors across the country to understand more about how the duty to refer is working in practice and the extent to which it is preventing homelessness. So these discussions will kind of help us to formulate a report and a list of recommendations for NHS commissioners and the government to support more successful implementation of the duty, and hopefully, obviously, therefore, better outcomes for patients at risk of homelessness. So we've spoken to lots of NHS staff, but we'd love to hear about your experiences and knowledge of the duty from a mental health perspective. So for today, we have a few questions we'd like to discuss with you all. So hopefully it'll be a bit more interactive rather than just us speaking at you. So please do feel free to pop your hand up, and if you'd like to contribute. But I'm also conscious that there's quite a lot of us, so do feel free to use the chat as well to share any comments, so that if we don't get around to everyone in the session, we can pick up any comments from there as well. Chris, is there anything that I've missed, or should we get started?
No, I think that makes sense. I guess the only thing I would add is that we know that the success of the duty is often reliant upon the wider services around it and the wider kind of organisations and kind of multidisciplinary approaches. So we're interested in hearing about how the duty to refer is working itself and also how it fits into, I guess, the wider homelessness and health system.
Great. So I wonder if anyone would like to kind of get us started and maybe pop their hand up just to speak a bit about their experience of the duty, kind of maybe how it works in the area that you work in. So we're conscious that it works differently in different locations as well. So would anyone like to be brave enough and kick us off? Oh, and I know someone will want to.
Interesting silence. How relevant is it? How many mental health services ever do it? Jenny, you're on mute.
I've forgotten I've muted myself. I just wondered if no one is coming forward, if you could maybe remind us what the duty to refer entails and how it's meant to work.
Yes. So the duty itself, as I mentioned, is part of the Homelessness Reduction Act, and it places a duty on specified public bodies, hospitals being one of those, including mental health hospitals, prisons, job centres, to refer service users who are at risk of becoming homeless to a local authority housing team. The detail is kind of, well, there isn't much. So different areas will have different processes. Philip, do you want to come in there?
Yeah, I was just wondering, am I right in thinking that there isn't a duty in the Act for community mental health services to refer people?
No, it's only inpatient.
Right. That may be why we're all, well, and I'm not involved in that, I'm retired mainly, and that may be why there's this awful silence, is because
It's inpatient
and apply to us. I mean, it probably should do. Do you see what I mean?
It's inpatient and A&E, isn't it? So it includes places safeties are obliged to do it. I mean, people sort of talk about doing a duty to refer is my experience, and then that's something that has happened. But I'm never quite sure what happens next, because it might be that it applies more to the people who don't come under our care and who don't get to the stage of street homelessness. Perhaps if it's working well for us, I guess we get embroiled in the same discussions with the housing departments that we always have done, and we discover that there isn't enough housing for people. And I don't know, I haven't made a duty to referral myself, but I can see a hand up from Denise from Cheshire.
Hi, yeah, I'm the homeless mental health practitioner on the Wirral, and I just do a duty to refer. If I know somebody who comes in who I know might not be open to housing options, they might have come through our single point access via that referral, A&E, psychiatric unit, I either advise the ward to do a duty to refer, or myself, I just complete a duty to refer either way, just to make sure that our housing options service are aware that they have rough sleepers or people who are at risk of losing accommodation, so that they can intervene at whatever time that they need to. So I just do it routinely as a community worker, whether it's right or wrong. It's a 5-minute online referral form. Probably takes less than that. You just need the person's consent. You don't need any other details, just a bit of background as to what the current situation is. And then what I do is I just there's boxes to let them know where you're referring from. So I just put community mental health, and usually it's picked up and a caseworker is allocated. So that's my experience. I often get called the housing officer, so the people in my trust don't actually know what I do, and I think the role's been there 7 years or even longer potentially. But yeah, so I just try and encourage everybody to do a duty to refer. So that's just my experience.
And how do you find the process, and how do you find the response from the local authority? Do you think it's working as it should?
I think it varies depending on some people will get back to me and say we'll get in touch with them. So I've got a young gentleman at the moment who's sleeping in a van. So I completed a duty to refer because I didn't know if he was known, they'd spoken to him, he said he was in a car. So I promoted that duty to refer, come back, he was open to housing options. And then what I did was tried contacting him to see if we could follow that up, to see if we could get him somewhere more suitable, or get that kind of homeless application assessment started with him. A lot of the time they lose their numbers, they can't get in touch with people because their mobile phones aren't charged. So that's probably the difficult barrier, is actually getting housing options to contact the people who have got no kind of contact details, because our council one-stop shops aren't open the same as they used to be before COVID. So everything's done online at the moment.
Great, thank you. That's really helpful.
Yeah, sorry, and other things they ask for, like ID, 3 months benefits, proof of benefits. They want screenshots of their universal credit. They want evidence of their national insurance. So that sometimes is more of a barrier as well, I suppose, in that process.
Great, thanks. That's really helpful to know. Jeff, I see you've got your hand up.
Yeah, I was just wondering, is there like a certain level of qualification? Sort of, does it have to be sort of senior management within a NHS trust that does this referral, or can a nurse on a ward do it? Can anybody do it?
Yeah, I mean, anybody can do it. It depends on what the hospital processes tend to be, and they often differ. It often is the responsibility of the specialist inclusion health service in the hospital, if they have one, though we know that some hospitals are trying to get more kind of it done more routinely across wards and across the hospital. So it can be anybody. It just depends on what approach the hospital decides to take.
Real.
I think another way of looking at this, because we know a lot of hospitals are not doing the duty to refer at all, and I guess there's a big overlap between duty to refer and hospital discharge. And so I wonder, I know that most people here are working for community mental health services, but I wonder whether you're involved in kind of hospital discharge planning and hospital discharge processes, and if so, how you think hospital discharge on the whole is going for people experiencing homelessness. Dave, yeah.
I think it can be really variable. In the hospital that I've most connection with, in fact, I'm taking over an ACD role in the inpatient services there. There is a hospital discharge officer from the local authority, so the NB who doesn't have a discharge address will come and will be seen by a hospital discharge officer who will come and try and, number one, assess their recourse to public funds and then put them into the local authority housing pathway, which works well, I would say, ish for people who have recourse to public funds. And as soon as they don't, then it's really difficult. And I wonder if there's things that we should be doing differently or better for those people. There's, you know, if they've got real high needs, then obviously you're trying to look at social needs assessments. But again, if they don't have recourse to public funds, that's often a barrier from the local authority, and it can take a really long time. And then obviously there's kind of pressure from the wards to create beds because we've got no patients, no beds anywhere. And so quite often what happens is that people who are seen as medically ready for discharge but not socially ready for discharge might get discharged in a kind of panic towards the end of weeks, or there are a number of step down beds where theoretically people are allowed to have their ongoing social care needs assessed and met. So the reality is there's much more pressure while they're still on the inpatient ward. So once they've kind of moved into the step down beds or into bed and breakfast, there's less pressure for that to happen. Also, they're less kind of a captive audience on the wards. You know, the social workers can come on and see the service users and assess their social needs. If they're out in the community in the B&B and they're coming and going, it's much harder for that to happen. So I think my experience is there are some safety nets in place in Newham. They're pretty leaky, particularly for no recourse to public funds people. And I would love to have a much more clear kind of set of responsibilities, not just for the hospital, but for the local authority, that they should be providing care for people. You know, it's not that long that basically the discharge planning was giving people a kind of photocopied list of homeless shelters that was probably 3 years out of date, and kind of like, you know, this is it. You can engage with a returning home process, you can have a list of hostels, or you can take your chances. So to me, I think, yeah, I can speak on behalf of Newham Hospital. I think we're probably not as bad as some places are, but I certainly think given our pretty mobile population, many of whom have no recourse to public funds, I would love to be clearer on what tools we could kind of pressure local authority, particularly, to kind of take on these responsibilities to avoid homelessness. So I feel like I'm a wee bit one step back, maybe.
Great, thanks, Dave. That's really helpful and chimes a lot with what we've heard in other workshops that we've run, particularly on NRPF being a major challenge. Really take that on board. Sarah or Sarah? I'm not sure.
Hi.
Hi.
Yeah, I'm at Camden, Islington. very much echo your experience that Dave, that you've just described. Everything seems to be led by the pressure to discharge and free up beds, which is just the sign of the times that we live in. We have a discharge facilitation team that we work quite closely with, and that's quite helpful. There doesn't seem to be any step down, which I think would be really helpful, because when people are on the acute wards, it's just about getting them out, usually to a solution that's not long term, or the hospital will pay for a hotel B&B for 2 weeks, which we then extend, which doesn't really give us enough time, particularly when people have got complex issues that we need to unravel, such as NRPF. So a bit of a mixed bag.
Yeah, thanks. Step down accommodation is coming up a lot, and the need for a lot more provision. So I think that's certainly going to be one of our recommendations for this piece of work. Jenny, did you want to come in?
Yeah, just to say that our situation sounds worse than Dave's. We don't have any bed and breakfast anymore. The trust isn't funding it, so they're currently writing a discharge to the street policy. And I can see that Denise has said that there's discharge to homelessness in her borough too. You did remind me that it was worse maybe 20 years ago, when people just used to be discharged with a letter to take to the homeless person's unit saying, I'm homeless, do something, and I sort of accepted that as an SHO. That's just what happened. And then in the past few years, we did have people in bed and breakfast accommodation for months and up to a year. I think I mean, talk about this forever, but there's such a pressure to get people off the wards. They don't have very good admissions. They're just discharged as if the main point of the admission is to get people out of hospital again, which, you know, is a bit depressing. And then they were going to still like very unwell and difficult, therefore, to make any progress with their social situation, going to bed and breakfast where they would linger for ages, often until we thought that enough time had passed that we could do another mental health assessment, which is a bit depressing. But now that option's gone, there aren't any bed and breakfast, so I don't know where people are going to go because there isn't any housing. It is quite depressing.
Yeah, definitely. Thanks. That's really helpful. Ali Noor, I'm not sure if I pronounced your name right, but
Lily is fine.
Okay.
I tend to harp on about this point, but I think also even when there are bed and breakfasts available, they're not suitable accommodation either for someone who has just left hospital, is highly distressed, potentially in pain, has medical needs that need to continue to be addressed, and so on. And there was I worked at a homeless shelter in Canada where one of the very different structure to here. The whole shelter slept 300 people, but there was a floor that was specifically for people who had just been discharged from hospital and who needed some degree of medical or healthcare professional oversight, where we had, I think it was a healthcare support worker and a nurse who would be there just for things like even helping to change bandages, but also to make sure that people were able to take their medication, and that if they were worsening overnight, I think a lot of people understandably are quite wary of following the worsening advice when they leave hospital, because they think, am I going to end up back in hospital, or am I going to get told that it's my fault because I wasn't following the right guidelines or whatever it was that I needed. I think that step down care is really important in the same way that older adults, you would hope, for example, you know, I used to work in an older adults mental health service, and we would say sometimes, unfortunately, people were discharged to a care home or to supported accommodation as opposed to being discharged back into their own flat, which even then would have been preferable to the streets. So I think step down care and looking at maybe other models and where that's been done elsewhere is something that would be really valuable.
Great, thanks. Yeah, that's really helpful. And completely agree. There's a lack of suitable provision for people coming out of hospital. That's certainly something that we're looking at. Are there any more points on that question? Emily, should we move on to? Oh no, sorry, Philip. Do you want to come in?
Yeah, I just wanted to say my anxiety about the duty to refer was always that its usefulness was going to be limited by the availability of resources. And talking about step down is, I mean, it's sort of a good idea, but it feels as though we're starting to talk about almost recreating asylums to cope with an increasingly unequal and impoverished society. I think it may be the, this sort of group step down may be the only practical way of addressing many of the issues at the moment. But my anxiety is that these things get institutionalized into the same way that the old large hostels where I started had become, established over a period of 100 years. So I do think we need to be careful about thinking this, and the trouble is we are stuck in a really difficult economic situation. I just don't want to lose sight of the fact that we shouldn't need step downs.
Yes, thanks for that point. I think that's a really interesting challenge, and not certainly something I had thought of before. I guess one thing Crisis is really interested in is shifting kind of, I guess, over the long term away from temporary accommodation, hostels, to a housing-led approach to homelessness, whereby somebody just gets given a house straight away rather than having to go through hoops. And I imagine that kind of step-down accommodation could play a role in a housing-led system whereby it's just short respite care before you move somebody then into a more permanent home. But I completely take your point that we could be in danger of utilising step-down accommodation in a slightly more problematic way if we don't then have the housing-led system elsewhere. Yeah, thanks for that. That's a really interesting point. Alex, did you want to come in?
Just on that point, Phil, I thought was helpful in the NICE guidance. They didn't call it step down, which perhaps could be endless, but they just called it intermediate care facilities, which says this is still a health-led resort place of care, continuing treatment, where you could still do the onward housing advocacy, and therefore trying to avoid talking about facilities which then become, as you say, they become self-fulfilling prophecies of back to 300-bedded Canadian hostels.
Yeah. Canada's an excellent place, let me say. I'm not in Canada at all. But yes, it's but we all know what happens to intermediate care. If you can't get people out, it becomes long stay care again. Well, that's the danger anyway. I'll finish.
Great, thank you. Emily, is it worth us moving on to the next question?
Yeah. So we had a question that was kind of around blue sky thinking, and we may have touched on this a bit already. But we wanted to kind of talk about what you would like to see in an ideal world that would allow mental health services to play a greater role in preventing homelessness. So obviously we've mentioned the need for step down or intermediate care, but there's also not becoming too institutionalized. A couple of people have mentioned discharge to the street is still happening, so obviously it'd be great if that wasn't a thing. And I just wondered if you had any more thoughts about the kind of in an ideal world, what hospital discharge would look like and how mental health services would play a role in that. Go on, Philip.
Okay, can I talk about the good old days for a minute? There was a time when START, the mental health outreach team in South London, had access to 3 Thames Reach housing projects. We could either get people straight in off the street into a small flat or bedsit of their own, or get them into hospital and get them discharged to one of these places, which you could call intermediate care, because they were you had about 2 years to stay there. There wasn't any requirement of treatment. There were services coming in, drug and alcohol and mental health services. So it was a sort of semi-housing first model. And I think that on the whole that worked pretty well, but it was in a different time when you could get people out the other end when there was housing available. And I'm not in touch with that at the moment. But that was one solution that worked, in my mind, very well in South London until the boroughs took it over and kind of basically took the beds for their own uses, took the places there for their own uses. But it had the advantage of being specialist in terms it was staffed by housing workers, and the mental health team came in and provided input. But there was a relationship, a continuing relationship between Thames Reach and START team, and my sense is that worked very well. But apparently it's not working that way anymore. So it's my little trip down memory lane.
Yes, that is something that has come up quite a lot in our discussions, is that relationship between housing and health workers. And there are some really good practice examples of where health and housing have been integrated, with housing workers placed in hospital wards, for example. But like you say, that doesn't happen everywhere, and it doesn't happen all the time. Is there anyone else that had any thoughts on that question? Kind of blue sky thinking. No?
Well, shall I chip in again? I suppose the whole thing of housing first sounds like a great solution, but too often it's a brand rather than an actual thing. I visited a service in Rome where they said, "We got a housing first service," and basically it was, people crammed into small rooms. It wasn't housing first in any sense at all, but that's what you want to call you need to call your service housing first to get money now. But I think I understand there's a housing first service working well in North London, but I don't know anything more about it than that. Alex, you may know a bit more about that than I do. But it seems to me to be the ideal solution that we should be working towards. But it does require, the problem is, it does require an open-ended commitment from a whole range of services to provide services to those people in housing first, and that's a big ask, especially at a time when everybody's trying to defend their budgets.
I think that's really interesting, Phil. I was just wondering, colleagues, what your experience of patients you've worked with who've ended up somewhere, perhaps have come through your services and have ended up somewhere in settled accommodation doing quite well. What is that? What is that accommodation? Where do they fetch up? Are they in the private rented sector? I mean, I have a feeling that there is really a need for some long-term, different kinds of long-term semi-supported and maybe heavily supported housing of different types. But where do people end up where things have gone quite well for them? That must happen sometimes.
Can I jump in? Yeah.
Yeah, please do.
Yeah,
Sorry. My name's Lily. I've just come from working from the North London Housing First team. So luckily enough, in North London, in Islington, we actually get social housing for the Housing First clients. So I was looking after 6 clients because they're all very complex and intensive. You have to work really intensively with them because a lot of them come either straight from the street or maybe from a hostel. So everything's quite chaotic, but we've had some great outcomes. Like one of my clients is completely abstinent. Like a couple of them have had to move because the area or the flat hasn't suited them. But if you're working to the Housing First model and like the fidelity of the model, then you are allowed to move the clients up to 5 times. So there's a lot of leeway with that. Philip, whatever you were saying about this place in Rome, yeah, I'm not sure about that, but it doesn't sound like the way that we were working. We're extremely fortunate to have social housing. I know that in Redbridge they use private rented, and that comes with its own set of complications. But even though I've just moved away from Housing First, it's just an amazing model, and it really does work really, really well. But I know obviously lack of accommodation can cause issues with that.
I think Housing First is the model to go for, but it's got to be the full model, the proper model.
Yeah.
And private sector rented, having talked to my patients over the years, complete waste of time, because basically there's no security of tenure. And if for people who have spent 10 years of their lives on the street or being moved around, being at other people's beck and call, security is a pretty important part of what they need, of what we all need. And so unless you're a bright young professional with loads of money coming in, then I don't think private rented can ever be a good answer to this.
Right, I'm really pleased people have mentioned Housing First, because that's music to my ears. Crisis does a lot of work in this area. Our own research shows that we need between around 16,500 and 30,000 places. And at the moment in England, we have 2,000 places, so a long way off what we actually require, and we're pushing national government on this very much. And also, Philip, to pick up your point around fidelity to the model, we're in active conversations with DLUC about this at the moment, because we know there are many housing first providers that aren't actually providing housing first, and that is becoming more of an issue. So yeah,
thanks.
Jenny, did you want to come in?
Yeah, just to say, I've seen some really good outcomes with Housing First. You know, things that people doing well who I never thought were going to do that well, and I've been astonished and delighted by it. But I think, as you say, the problem is that there's not enough housing stock. So we do have, in all of the boroughs, we've got Housing First projects, but it's very difficult to get into them. We have a long wait for a flat, and I think that means that it has been quite selective about who goes into them. And I'm not sure that we yet have enough evidence about, for the most difficult, complex people with the most complex needs, how well they would do in the model, because I think up to now people have been selecting people who they think are going to do well, or in places I've worked, that seems to have been the case. And I was just going to also echo I think there needs to be a range of solutions for people. I think some people, we've had patients who do well in supported housing. And I don't think there's enough of that, like good quality, small hostels where people are getting lots of input. And some people, I think, are going to always need that. And also to echo what Phil said about private rental, I was speaking to a man yesterday who was in a No Second Night Out project, and he'd been put down for private rental. And I thought he'd be quite pleased, because I thought he wouldn't want to go to a hostel. And he said, why are they doing that? I don't want to go to private rental. I've done it before. I always end up back on the streets again. Yep. They're just dooming me to failure. He was very eloquent about it. And he said that his experience is that you go to somewhere like Housing First, people start listening to your needs and trying to help. And then he said, then they get fed up, and I've been here too long, and someone else, there's a change in staff, and they say, you've been here for ages, you just need to go, and they just take whatever is available at that point. And I thought that was quite insightful from him. It's the sort of time pressure that, because everything is time limited, it's the same with hospital discharge. You don't find a perfect solution, you find a solution that is there, and you might know that it's not necessarily going to go very well.
Jenny, can I just take you up on something you mentioned earlier about the difficulty of handing on or referring people onto services that you're not actually sure are going to serve them well? With your clients who went to Housing First, was it the START team that continued to provide the mental health support, or were they transferred to a local CMHT? No,
we've continued to provide mental health support.
Right.
And I think that's in our contracts that we work with them, at least until they're settled and we're sure it's going to work, and then we can move them on.
Right, okay, thanks.
But in fact, for a number of people, we've been able to not hand people on. They've had such good wraparound care from other services that they haven't need ongoing mental health support, and they've been discharged with GP.
Right.
Thanks, everyone. I'm just conscious of time. So if we go to Dave, Nick, and then Freya, I think you're the last ones with your hands up.
Just three quick points. The first one's around blue sky thinking, and to me, working in Hackney, Tower Hamlets and Newham, where there's massive gentrification, social cleansing going on with all these new builds, my understanding, when the buildings first go up, there's supposed to be, I don't know, 20% of the housing stock is supposed to be social housing, and then during the course of the build, due to extra costs, and I don't know what processes, that commitment to provide social housing often gets reduced. And for me, blue sky thinking would be trying to hold that to account a little bit, because it feels you're a bit complicit, that you're a part of a housing system that is continually placing people out of borough, number one, when they've got kind of connections there, particularly. The second point is around the kind of relational stuff and building on that. For our, I don't disagree with the idea that the work we do is around building trust, establishing relationships, and then to have housing stock in our own borough, blue sky thinking, it would be really good that people stay in the borough that they start off in. To me, really essential, almost more so for our service user group. And the third thing is, I think there are opportunities when we talk about the kind of wraparound care that you need for housing first approaches. I know quite a few mental health trusts have also brought up community health services. So, you know, in ELFT, we've got access to GPs, community nurses, dietitians, and, you know, to kind of have all of that as part of a service that can provide care for people in houses, you know, in independent accommodation, and be really committed to try and meet those needs and do it in a kind of creative and flexible way. Sometimes working within one organisation that has a kind of philosophy and a value around that can be helpful. Though obviously I'm aware the ultimate goal is that people are then supported by services that exist locally. So yeah, just three points.
Great, thanks. Nick, did you want to come in next?
Yeah, thanks. It's picking up on a lot of the stuff that's been said about Housing First, particularly Phil's points. Good to hear that Chris, you're in touch with DLUC about this, because what we're noticing is a kind of patchy delivery. There are a number of drivers, I think, behind that. So one is that, of course, if you're a local authority and you're driven because you think you ought to be doing Housing First, but you haven't resourced it, or you haven't been resourced to deliver it properly, the first thing to go is the wraparound support. And we'd argue that actually the mechanism of change in housing support, one of the most important things is the wraparound support. It's the interpersonal stuff, and so you get a reliable relationship being established. Secondly, on that, I think we can be, you know, picking up on the kind of, we need to be person-centered. We can't assume that everybody is going to value the same kind of relationship. So differing attachment styles, you know, associated with different forms of childhood trauma are going to dictate the kind of, or influence the kind of relationship that person might want. So somebody anxiously attached is would be predicted to want a more reliable and relationship and a reliable person to keep turning up, and that's going to be really important for them, whereas somebody more avoidantly attached might just value the functional stuff, so the kind of the support aspect to it. And we can do something about that. We can help those support workers in managing, in assessing and being able to be flexible and understand what it is their people need. And on that, the other thing that I've heard from some of the support workers delivering that wraparound support is they feel quite isolated and lonely. And I wonder whether there's something we need to be doing, building in an infrastructure of support for those support workers, training and support, so that they know what they're doing, they know what the expectations are, they know they're not going to fix the problem, and they're able to kind of attune to what the kind of relationship that that person wants.
Right, thank you. And finally, Freya.
Hi Chris. I'm sort of just echoing what I think what Jenny said earlier about how, well, in terms of sometimes Housing First can be seen as this panacea, so like a fix-all sort of thing that people come out of hospital and we're in place. I work in crisis Housing First team, but actually we're seeing people that potentially are too high needs for Housing First, whereby if we get involved, other services then step away because they think we've got it all under control and we'll fix it all, and then we've recently, unfortunately, we've just lost a member who needed such a high level of physical health support, but he just didn't get that because the carers weren't doing, going in as much as we would have liked, because they assumed that our team, the lead worker, would be going in. And so actually we felt like he needed he should be been stepping out of hospital to a supported living facility whereby he got his health and social care needs met there. So it's just, I'm just so mindful of always thinking that Housing First is the answer, when actually often it's a supported living which can provide more than a Housing First team can.
Great, thank you. Thank you, everyone. That was really useful. Chris, was there anything else you wanted to cover quickly, or should I talk about next steps?
No, that was already helpful. Thanks, everyone.
So just very quickly before we pass on, as part of the research that we're doing, obviously having lots of discussions, we have also developed an online survey that is designed for hospital staff to complete. So the first few questions kind of establishes staff's understanding and knowledge of the duty, and then the second part focuses on how the duty is working in practice. And obviously I know that not everyone will work in a hospital, but I'm going to pop the link in the chat. If you have a spare few minutes, if it applies to you, please do complete it. and also feel free to share with your networks as well. We're happy to hear from all kinds of backgrounds, whether you have extensive experience of the duty or whether you've never heard of it. We're hoping to finalise the report by the end of March, and we're keen to share that with you, obviously, so that you can see how these discussions have fed into the recommendations that we make. So we'll keep you all updated on that through the Mental Health Network. And I think that's it from us. Thank you once again for your contributions. It was really useful.
Thank you, Emily. Thank you, Chris. Really good to think about it and have a bit of a moan about housing. But it's great that you're doing this work, and I hope that the duty to refer evolves and keeps going, and we can get some positive outcomes. So that's it for our scheduled speakers today. What's left is we were going to have a hot topic discussion about gosh, I just wrote it down and then I've lost what it said again. How homeless mental health doesn't get lost in an NHS in crisis, which I think follows quite nicely from the conversation we've just been having. If we can think about what the problems are and how we can try to address them. But I'm just aware we've all been sitting down for an hour and a quarter and people might like a little comfort break. I might like it. So good. Kathy would like a little comfort break. So shall we just have 5 minutes and meet back at 25 past, and then we can have half an hour discussion? Okay. But so thinking about this topic, it does sort of follow on from what we've just been discussing about housing, but it'd be good to think about whether people have noticed more pressures from the NHS crisis, and then to think about what to do about it. I mean, I think the main thing I've noticed is this not very adequate inpatient admissions and then lack of people to go afterwards. I don't know what other people have found.
I mean, broadly speaking, I think my experience has been a withdrawal, a sort of defensive withdrawal in terms of just even subtle definitions of what is acceptable as a referral, like what the sort of criteria are, has incrementally shifted in different services to the point where, you know, I think it becomes more excluding. And again, relates to my earlier point. I think one of the things that we might have to sort of argue back at that is to try and broaden out what mental health work might be in a particular area. There might be other ways of providing care and support that don't involve sitting in rooms with people talking about their mother, but that services might be able to do something else other than their more traditional modes of operation, whether that's case consultation, reflective practice, just being around at the end of a phone. There might be other ways in which services can be useful that don't involve direct, more time-consuming care. That's the argument I've been trying to make.
I saw a hand. Thank you, Adam. I was just thinking when you were saying it that I think that is important, like thinking about how, without relying on services that aren't going to provide the services we want, whether there are other ways to get the help to people who need the help, but also to keep saying that the services who are providing the right services aren't doing well enough. Like, it's quite hard. I find it quite hard to have those two things in mind. Emma from Leeds, hello.
Morning. Yeah, this is a pretty emotive subject for me at the minute because I'm clinical team manager and psychotherapist in a fairly new rough sleepers mental health service here in Leeds. It's the only statutory service provided, and I've been in post since about August last month, and I think this sums it up really. I've been redeployed 2 days a week to CMHT and 1 day a week to primary care mental health, to clinically supervise a lot of the staff and to see patients, and I've been kind of arguing back in the sense of, you know, my service is a preventative measure to prevent people from getting to CMHT and going to primary care mental health, and by taking away provision in my service, you know, and putting it into another, then we're gonna see stuckness again, and we're gonna have further issues. But I think there are major issues within CMHTs across the country, and particularly here in Leeds. And unfortunately, it's kind of just been told, look, this is what you have to do, this is where the need is, and then the impact that this is going to have on the service users for my service, but not only the service users, but the wider street support network here in Leeds, because we provide consultation and training and formulation work and other things that have just been mentioned. And now I'm down to 2 days a week, you know, in my service that I'm obviously employed in and commissioned to do. So yeah, it's really tough. And I think I've emailed people, you know, I've gone to ops managers and whatnot, but it's them seeing or not seeing the need of the rough sleepers and homeless service that I'm really struggling with. And I feel like I've exhausted all my possibilities. And so not really a solution there, more of the frustration and the experiences that I'm experiencing here in Leeds that I am sure that are mirrored across the country. But as well, we're a really, really small service that, you know, we're still in recruitment phase as well. So there's only going to be 5 of us all together. So a major impact on the statutory mental health service for rough sleepers and homeless in Leeds at the minute.
I'm really sorry to hear that. It's really difficult, isn't it? And it seems very short-sighted when the sort of predictions are that because of all the various crises, the number of rough sleepers is going to go up. But it seems very short-sighted to withdraw support. There's lots of hands up, as I thought there might be, and I'm not sure who's went up first, but I think it was yours, Kathy.
Hi. Yeah, I mean, I'm a non-statutory mental health professional working across London with EASL, and so it's quite interesting because I work with so many different boroughs, and you kind of have who's the best and who's not so good. And oh, I'm so sorry, that's my dog.
It's difficult to know how long the dog will.
Hello,
oh, she's back. Oh, we don't get to see the dog. That's a shame.
He's heard me complaining quite a lot, so I think that was his contribution. I've got what I was going to say now. But essentially, I worked within the statutory sector for 23 years, so I kind of, you know, I'm within the homeless sector, so I've watched the changes. I mean, I think back in the 90s we were still facing a lot of the challenges we face now, but it felt like we were evolving, and obviously resources are just becoming tighter and tighter. So I understand the statutory sector pressures, and I think, you know, I'm sure I echo a lot of people's thoughts. You know, I often pinch myself and remember how it was, and I wonder, you know, I think it's the barriers for me is the immediate defence, the wall that goes up just from a referral, and the lack of willingness to contribute to a discussion. You know, even if we aren't going to get an immediate statutory assessment, even when it's clearly warranted, and I think my reports a lot on evidence, very, very clear statutory mental health need. But it's the barrier just seems to be that absolute, sometimes really negligent responses, which is really, really worrying. And I just feel like who was the gentleman that spoke first about this? It's about perhaps, you know, really trying to ask the statutory sector to contribute to discussions, even if they're not willing to engage in offering an assessment from the onset, so that myself as a non-statutory mental health professional and my outreach colleagues who are holding some of the most complex and vulnerable clients with really, really high risk behaviours, because it is a statutory responsibility, but somehow certain boroughs in particular will be really, really resistant to any kind of engagement at all. And you know, even when safeguardings have been raised, and you know, and even then adult safeguarding processes don't always get followed, but that seems to be, to me, the way to go forward a little bit, because I find that when I do raise safeguarding alerts with adult social care, I kind of keep pressing for their involvement, and they'll often reject intervention because they'll say it's a mental health need. But I will argue that this person needs safeguarding, and they will often then participate in some sort of meeting, which might sometimes contribute towards the referral process within the mental health system. And it can sometimes take months, but sometimes we get there and sometimes we don't. But yeah, it's very frustrating.
Thank you, Kathy. It must be very frustrating because I love your reports and the level of detail. I know it must be very frustrating to write them and then be ignored. And then frustrating if then they do get a service and the service isn't very good, I imagine, as well. Jonathan has kindly told me what order hands went up in, so I am going to call Dave Bailey.
Hi there. Yeah, just, I mean, to reiterate what you said about the challenges, you know, the difficulties of getting people into hospital in the first place and the pressures in trying to get people out, which means they're not properly sorted out before they go, but also sometimes there's so much activity and not enough time for reflection and thought, so that it feels a wee bit superficial. A lot of the time bits of psychology just kind of get missed a wee bit in a kind of thought and a formulation. A lot of the stuff that you'd hope happens during an inpatient admission just often isn't really happening, and it feels like one of the roles that we have within homeless services is to almost do a lot of that gathering of information, thinking, formulation, creating a narrative to sort of hand it on a plate to the inpatient services, and then kind of often shepherd their transfer into mainstream services, whether that's mental health or housing, just by kind of reminding people of, no, it's not necessarily a truth, because it's a kind of hypothesis and a collaborative conceptualization that we've come up with people, but just to try and use that to help advocate them within services that are raising the bar more and more. In terms of the points about whether we should be offering things other than direct contact, absolutely. Formulation discussions, supporting the system, you know, with that, you know, a lot of that kind of work I think is really important. And I think we have a bit of a privilege of time and opportunity to almost continue to fly the flag for that sort of way of working, think about relationships and understanding people's mental health problems in a bit more of a deeper way. And so I think that's what we've got to bring, and the kind of value that we have to kind of advocate for our service users within the system. I think there's a real going into inpatient services to try and help them be more effective. I can see that a lot of the things I would like to do is try and get people to, you know, not discharge so quickly and spend longer on admissions. And I can see that there'll be a real tension between those two things. So I'll be interested to see how that evolves going forward.
Yeah, I mean, we do a lot of advocacy, but it's quite exhausting, to be honest, isn't it? I think it's sort of like, I think the team are finding it quite tough that everything you want to happen, you have to spend such a long time advocating for people for. And what you're saying about lack of time, I think then we're so busy because of that there's less time for us to be reflective as a team. So meetings like this, I feel are brilliant, because it gives you some time out of just the continual, like, one thing and then another that it seems to be at the moment. But I'll stop talking. Nick, I think your hand went up next.
Yeah, thanks. I guess my argument has always been for that it's very difficult for statutory services to be able to respond to the people we serve, particularly people, you know, if we think of a continuum of people who are sort of, you know, engaged or disenfranchised, and the group of people that we're trying to serve are very much kind of moving between rough sleeping and into hostels, and out of hostels, sometimes into private accommodation, but bouncing around. And the argument is that it's the way in which the service is configured. So if health services are configured in a way to serve a whole population, the drivers are to look efficient, and efficiency counts as number of people seen. So therefore you get into metrics around outputs. In other words, how many people have I seen today? And of course, that's based on an assumption that people, A, are interested in their own health or mental health, B, will turn up to where you are providing that health, and C, will appeal and follow the regime that you specify or follow, or that you think is going to be around improvement. And it also relies on simplification. So we simplify the complex through things like diagnostic processes, the forms of assessment we categorize. And those oversimplification processes can get in the way of an understanding of the experience of the individual, the experiences of how they're interacting or not interacting with various services and various people. So if you've got those drivers, then you can't cope with people who don't turn up, who don't appeal to the assumptions that you've made about how your service should operate. So you have to go out to people, which looks less efficient. So you have to go to hostels, you have to go to day services, you have to go to the street, and that looks less efficient because you've got travel time to build in and stuff like that. And you also have to tolerate people not turning up to your appointments. So we have a mantra about turning up to be rejected, and you have to do that. You have to, you'll see somebody, you'll make an appointment. So yeah, I'll see you. And so you sit in the hostel, and they wander past and they glance at you out the door straight, and they're not going to come back. Next week though, they might sort of glance and say, yeah, okay, I'm just going out for a fag, I'll be back in a second. They're not going to come back. But the point is, you have done what you said you were going to do, which feeds into, and we're deliberately behaving in a way which doesn't confirm the way they predict we're going to behave. In other words, reject, not turn up, etc., and not be reliable. So the more reliable we can be, the more likely we are to be able to get change and engage in change. So this is about being clear about what change is taking place due to whatever we're doing. And the first bit is about the engagement bit, the relationship bit, being seen to be reliable. And that feeds into the point that was being made. I think, Adam, you were talking a bit about this, which I totally agree with, is change doesn't necessarily take place in mental health services. We have a thing, and it's entirely understandable given the complexity that we're trying to work with. We think, oh, what? Well, if I just refer to that specialist mental health team over there, they'll fix things, without valuing what you are going to do within the hostel or on the street. Because arguably, and totally agree with you here, Adam, is that's where a significant amount of the change takes place. Being reliable and being somebody who can talk to. Whenever I've asked people who have made significant recovery, what was it? And they've never said, I don't think I've ever had anybody say, oh, it was the mental health service that sorted me out. Most people say, well, there was this one worker and I was horrible to her, but she stuck by me and she was reliable, and I remember that. And that was, they might not have credited it at the time, but that was the thing that they remember as being significant in their recovery. So this leads me to think we're not, the NHS at the moment, particularly at the moment, can't serve people, the people that we're working with, in a way that we would like. So therefore, we need to provide those services in another way, and without making the assumptions that people are going to value care and going to turn up to places, and all the assumptions that kind of healthcare makes.
Thank you, Nick. That was nice to hear your words of wisdom. I like your mantra, turn up to be rejected. I'm going to spread that amongst my team. Thank you.
And fail better is the other one.
Fail better.
You're going to fail. Just fail better each time. Just a little bit of evidence, I guess, is so we've been working, we've got funding from HE and OHID to get clinical psychology trainees. We're trying to build the clinical psychology workforce, bearing in mind all the things you're saying about trying to get psychologists into so we're trying to inspire and train clinical psychologists, trainees, to work effectively in this area, because it requires a very different kind of skill set. And when they're supernumerary and they can work, so for instance, I've got 3 now working across the city in Southampton. They can go to the places. We get some amazing stuff happening. You get that cross-fertilization of ideas. You get silos breaking down, because you've got one person who's following a person through into different services. And so this, as soon as you're able to kind of move out of silos and behave in a way across a locale, you get some really interesting stuff happening.
I feel guilty now for all those times I didn't engage.
Phil, I think your hand was the next.
Yeah, just go back to Nick's observation of hanging around and being rejected. I think the mantra is also familiarity breeds content, because people, as you say, people learn you're reliable to be trusted, and it's something you need to do. But there may be an inbuilt problem with getting statutory services to do consultation liaison. It may be that there is no way to record this in their information systems. our START service was defunded in Lewisham many years ago because we did a lot of consultation liaison work there, but very little actually seeing individual clients. And there was a bit of a rogue commissioner who said, well, you're not seeing any patients, are you? So we said, no, we're doing consultation work. And said, well, that doesn't matter. You're not seeing patients. That's it. We don't need your service. And so we now find that people are rotting on the streets of Lewisham. But that's because of at least partially because of a built-in problem with how services record what they're doing. In terms of what Dave was saying about having to do the ward's thinking for them, I was going to ask Jenny, do you still use the admission plan at START?
Well, now I contact the consultants directly and tell them what to do a little bit.
Right. Okay. Because we used to have an admission form which was basically basic details about the patient and what we wanted from the admission in terms of medication, in terms of engagement, in terms of the length of the admission, and what we thought the outcome should be. There may be a way of kind of formalizing that. I don't know. So it happens with every single admission, so things don't get forgotten. But another problem with electronic systems is that people say, oh, all the information's on the system. Well, it may be there, but nobody bloody reads it. They really don't, because none of these systems are good enough. And so we do have to do, have to do the thinking for the wards to a significant extent, I think.
Yeah, it is still very difficult, probably more so, which is why I started just speaking to the consultants directly. But that's what I mean about the advocacy work. It's you sort of think it might die down a bit when people are safely on the ward, but it gets more.
I think the advantage with a written plan is it's a written plan and it's there on the system. Nobody can say it didn't exist. Nobody can say the phone call wasn't made. It sounds a bit adversarial. But I've had numerous kind of poor experiences of wards over the years, which have led me to this decision that you have to be a bit bureaucratic about it. Anyway, there we go.
Lily.
I just really quickly, and then I've got a dash, but I think what you were just saying, Philip, really resonates with me. I think I work with the CMHT, and it's one of the things that we have to argue all the time. Why do we have a slightly smaller caseload in terms of one-to-one patient appointments? Well, because we do consultation and formulation and reflective practice and case discussions, and we review severe incidents, and we say, oh, this person's maybe going into hospital. What could we do to make this as safe as possible? And one of the bits of feedback that we get is, well, you're not measuring that, and you don't put that on track. Our sort of patient system is a way of tracking that you've done it, and therefore it doesn't exist. And I think it's one of the really frustrating things where the bureaucracy actually takes so much time and takes you away from doing some of the really meaningful work that you can do, but also following those processes when they could hopefully be streamlined means that you can justify a resource and say, and it's not enough, actually. Because I think it is that there are people where I have seen the patient once but have probably done 20, 25 hours of work relating to them and actually have very much said, this counts as someone on my caseload. I've only seen them once in passing while they're coming to get their depot. That doesn't matter. They are actually as much my patient as someone who I've now seen for 20 sessions every week. But I think we really have a problem with how we record those things to really show that value as well that comes in it.
Thank you. We've sort of come into the end. We've got 10 minutes, so we've all noticed that the NHS is in crisis and there are problems for our clients. I don't know if we've got any solutions to how we're not forgotten, and so I'm going to put Alex on the spot and see if he's got any suggestions about what pathway he can do to help us.
I don't know about solutions. A couple of things, news to share, I guess. So following, I think some colleagues on the call will have come. We had a masterclass with pathway teams with Michael Dilley about brain injury and neuropsychiatry, which was hugely welcome for all the pathway team colleagues, but also led to some follow-up conversations with him saying to me, Jenny, but we need to hook you into this. We need to just get after the Royal College and get even more action going out of the Royal College. On the back of that, he suggested we invite Laddie Smith to keynote at the conference, and she's agreed. So it's our first time we've had a consultant psychiatrist giving the Halligan Memorial Lecture. I haven't seen whether she's become president of the Royal College.
The voting closes tomorrow, so we
right,
can't
so,
make any predictions. So we'll either have the president-elect or the wannabe president-elect, I suppose.
Or the also-ran.
The also-ran. But so I think there's something, and again on that day we've got Professor Sir Steve Powis speaking to open the conference, who is medical director of NHS England. I'm sure he will run away and not stay for the afternoon mental health session, but we've got a way to speak to him, as it were, and doing quite a lot of work trying to influence Bola Owolabi. And it was interesting thinking about who's the National Clinical Director for Health Inequalities. In her core 20+5, people will recall that she's got severe and enduring mental illness as a thing. And in a way, sometimes I think our patients, our population sometimes even gets excluded from that group because they're kind of not cleanly diagnosed into that population. And so having said that, Bola is routinely naming people experiencing homelessness, multiple excluded groups, as she defines her core, the plus group. It's now in her rhetoric. So there's some kind of, there's some stuff there. What it's not translating to at all really is protecting money down at the level of service, or kind of, it just seems to be a huge gap between the high end top of the system rhetoric and as you get down into services, the pressure in commissioning in ICS is intense on budgets and any of those things. Phil and Emma were talking about that, unless you're seeing kind of, why haven't you seen 16 patients today? We've commissioned you to see this kind of, where's the efficiency, where's the cost releasing saving that you promised me from avoiding an acute admission? Everything is pushing into those kind of arguments, which are pretty awful for us. So not that optimistic, I'm afraid, but I think so politically, crisis were on the call earlier. We are in some discussions about how to maybe begin to talk to the Labour Party and try and see whether we can frame some of this stuff as part of what a new government might come in and see real value in investing in some of the right stuff, because you can see they're coming up with some slightly odd things, but they're talking about change in the NHS. I don't know whether you heard Keir Starmer saying, perhaps, I think we might need to do some work to rapidly see if we can educate some of that. But I think that's indicative of an opposition looking for some things to say and some ideas to back. So I think there's a bit of space there. Certainly we hear that they are on receive in the sense of listening for ideas and things that they could deliver in a new term. Of course, the financial circumstances will remain difficult.
Maybe one of them would like to come to the conference.
Yeah.
We did think about trying to get the shadow. So yeah, we haven't. So now the platforms are all full, but we might try again to see if we could squeeze them in, or even do a lunchtime thing on one of the days.
It sounds like the right party to focus upon anyway.
I think. In terms of how to defend people currently, in terms of money and services under threat, I mean, I think there is some collective action we can take, which is sometimes trying to give those individual. It is currently, I'm afraid, about kind of shouting loudest or embarrassing people in the press, or making it's talking to the Royal College of Emergency Medicine that the president carries a bloodied hospital gown in their bag in order to put it on for whenever they have to do an on-camera press interview, because you have to make things look serious. You need to be, what's the phrase, shroud waving is a thing, and in difficult times maybe we need to engage in explaining more the severity and the extreme nature of the things that you're all doing, and the risks of when these things go wrong. These risks are extremely serious for people, aren't they?
Certainly are. Well, yes, if we can get an audience, I think a lot of us would be happy to explain the risks.
So the other thing I'll just share, and Jeff, one of our stars, is on the line. So it's now less than 2 weeks' time. We've made a film with Groundswell, with some colleagues from our lived experience group, which is being launched with Victor Adebwale and Dame Ruth May, the Chief Nursing Officer, next Thursday evening. For colleagues who are in London, I'll I'll fire out an invitation at the Royal Society of Medicine for the kind of film launch. To 10 minutes short of colleagues with lived experience talking about their generally, Jeff, I'd say generally poor experiences of care, perhaps, and some.
Yeah, I think Paul's been kind, I think, yeah.
but kind of also very powerfully pleading for some relationships, some compassion, some care, as it were. So it's intended to be quite a straightforward hit between the eyes, as it were, to frontline colleagues across the service to say, just a bit of kindness, a bit of compassion, a bit of thought and humanity is a really good place to start. And even in times of toughness, surely everyone aspires to do some of that if they're working in the NHS. So we hope that's a bit of an asset. Again, it'll be on a website next Thursday. And if you wanted to start using it, we've put some kind of discussion questions around it to use it as a kind of training aid, just to get colleagues in all sorts of services thinking about, I hope, thinking about some of those relational things, I guess. Jeff, what would you, is that a good summary?
Make sure you've got some tissues with you. We did a session at the Chief Nursing Officers Conference a couple of months ago, and 80% of the people that watched it were in tears at the end. There was one woman at the back sobbing her heart out. I had to go and sit with her for 10 minutes. It is quite powerful. It gets the message across really, really well. As I say, it's only 10, 12 minutes, something like that, but it's really worth watching. And it's NHS England were the ones who basically decided.
It's got NHS England money in it, so they didn't quite know, but they funded it. So we've got NHS brand on it, which I think is helpful.
Yeah, it's definitely worth a watch.
Okay, well, that's a good thing to end on. Alex, can you remind us the dates of the conference for those of us who haven't signed up yet? Yes,
let me put the I'll put put a link to the website in the chat, but it's 15th, 16th of March. We've also just heard, which is nice. And I was thinking about the kind of outreach mental health services. We've just heard that we have got approval from Westminster City Council, parking approval, to allow colleagues who have outreach mobile services, for example, in vans or trucks or buses, to come and park up. So we're going to hopefully have a few mobile services find a treat. But there's Maggie from Bournemouth, I hope, is going to bring her bus, which tours rural Hampshire as a specialist homeless outreach bus. But anyone else, if you know colleagues who do things out of a vehicle, do tell them. But I was thinking it doesn't really showcase you guys who are often not in a vehicle, you're just on the street walking about. Perhaps we should get you all to stand outside and talk to people, because
it might still be -3.
A vehicle
Alex.
promotes something to look at, doesn't it? But actually,
okay, thank you all. I think people are leaving. Listen, thanks everybody so much for coming and taking the time. I think it's been a brilliant meeting this morning. I've really enjoyed it, and as always, I'm feeling fired up to continue fighting the good fight. Thank you again, Sophie, for organising everything.
And Jonathan, thank you.
And Jonathan for organising everything and sending things out. And please, I think, just finally, I think it is difficult times. It's difficult times for all of us who are working in the sector. So I'm going to try to encourage more of my team to come next time, because I think it is a really useful space, and it's useful to know that we're not alone. So please share the invite with people that you work with, and see you next time.
Bye.
Bye.
Thank you.